introduce the next speaker.
Okay, thanks a lot, Billy. So I believe, Francisco, you're ready. So now we'll be moving to the more modeling-oriented applications that have been attempted in response to COVID. And really the more appropriate chair of this session would be Elaine, so I'll soon be handing over to her. But Francisco, are you ready to share your screen and
yep,
presentation?
I'm already. Can people hear me?
I can hear you, so
okay.
Feel free to go ahead.
Thank you. Let me just see how to share the screen. Can people see my screen?
Yes, we can see your screen.
Okay, great. Well, thank you, Shira. Thank you so much, everyone. My name is Francisco Marmolejo. I would like to talk to all of you about resource optimal testing mechanisms for COVID-19. Very much akin to the questions that were being asked in the last session. And this is joint work with Jacob Johnerby, Edwin Locke, Christopher Ramsey, Megla Shukla, and Divya Sridhar, all colleagues here at the University of Oxford, and also many more colleagues in the Mechanism Design for Social Good research initiative. So the main problem that we're tackling, or rather we want to focus on testing. And it's widely acknowledged that accurate and extensive testing is important and essential to combat COVID-19. But unfortunately, as we've seen, resources can be extremely limited, especially in the in the developing setting. And these limitations can be in the form of just limited tests, in the form of limited trained personnel, or even lab time. And the question that we want to answer is how to maximize the benefit of these limited resources. Now, at any time that we talk about maximizing the benefit, we need to outline specifically the objectives that we're trying to obtain with testing. And in our work, we're going to focus on two objectives, that of minimizing the propagation of the virus. And also, more importantly, in the future, as self-isolation wears off, we want to minimize the impact of unnecessary self-isolation. Now, for propagation, we would like to prioritize people who are susceptible or who may spread the virus. And in terms of self-isolation, we would like to differentiate between people for whom self-isolation is more costly. For example, a hospital worker, we would not like a healthy hospital worker to stay at home when they can be working in a hospital, or possibly a daily laborer who might not have the economic means of staying at home for a couple of weeks in self-isolation. And the main primitive that we're exploring is that of group testing. And in a nutshell, the way group testing works, in case some of you haven't seen this, is you take the samples from multiple people, you mix them into a single sample, and you're able to run them through tests. And now the test will either be positive or negative, and if positive, it's telling you that somebody in the group has had the virus, and if negative, nobody in the group has the virus. And this latter outcome is actually very informative if the virus prevalence is low. This has the potential to drastically reduce the number of tests needed to tackle the objectives from before. And so this is not a new idea, and there's a substantial amount of literature. But normally the literature is focused on, you have a certain population and you're trying to find the smallest number of tests you need in an intelligent group testing regime to find out who does and who doesn't have the virus. What we're going to be doing is actually, we're going to throw the idea of being able to perfectly ascertain who has the virus out the window. And we're just going to focus on a very naive group testing method, which we call uniform group testing. So in this case, you have a population of size n, and you have a testing protocol with two parameters. So you have the number of tests that you give to the population and the granularity of the tests. And all we're going to do is we're going to simply partition the population into, we're going to take T groups of size G and allocate a group test to this. And we know that G can't be too large. There's an upper bound on how big G can be. And what we're gonna, the main thing we're gonna be looking at is, we're gonna have the population, and we're gonna have a testing budget. So this is already backwards from before. Rather, we're beginning in a constrained setting. And the population will have certain categories where, supposing that we come up with an intelligent categorization of the population, essentially we're gonna segment the population to the categories on certain characteristics where every category is going to have a certain probability of infection, a certain exposure to the virus, and this means being able to get the virus and also propagating the virus, a certain cost of self-isolation, and a certain number of individuals in the class. And I'll explain these a little bit more shortly. And essentially, the overall testing strategy that we're going to look at is segmenting the population according to the categories before, and looking at separate uniform group tests per category. And what this means is that the feasible family of protocols is going to be choosing how many tests to allocate to a category and at which granularity to allocate to the category. And in particular, so there are just certain constraints, namely these first two right here are just mean that I have a feasible group test for a specific category, where this constraint right here is saying that I can't have groups that are too large because there's an upper limit on my group tests. And this latter constraint right here is simply saying that I don't use up more tests in my budget. And so a testing strategy means nothing if it's not paired with a self-isolation policy. And what we're going to introduce a simple self-isolation policy, and essentially we're going to assume, for the sake of the current model, that there's a baseline infection, that individuals are tested, and then policymakers react accordingly in terms of imposing self-isolation. So at the beginning, people are individually infected with a probability of, according to their group, high risk, low risk, let's say. And subsequently, group tests are made. And if somebody is in a positive group test, then they are forced to self-isolate. And if they're in a negative test or not tested in the first place, there's no change in their behavior. And I want to go back to our objectives, because now these go hand in hand with the parameters that we have at hand. So we wanted to minimize the propagation of the virus. Well, what that means is that if there's a person who has a high risk of being infected, then and a high risk of spreading the virus, we would like to test that person for sure to make sure that they don't spread it to more people. On the other hand, if there's an essential worker or people who cannot self-isolate, then their costs will be high for self-isolation, and we want to balance these two things. And so here's the optimization problem, and I won't dwell too much on this because there's not too much of a need to go into the specifics of the math, but essentially we're balancing. Here I have a cost, this is measuring how much the virus is propagated on people that I didn't test. And this is measuring the cost of unnecessarily self-isolating individuals. And I balance, the optimization problem can be written as a balancing of these two things given this beta parameter. But ultimately, so we have an algorithm for solving this in certain small cases. But let's look at a test scenario for why segmentation makes sense. So, and this is a very trivial toy example, so by no means is this meant to be close to reality, but it's just to illustrate some of the ideas. So we have a village of 10,000 people, and imagine that 20 of these are key healthcare workers, and then imagine that there's one central marketplace that people congregate at all the time, and at this marketplace there are 480 regular marketplace workers who are very exposed. So these guys have a high DI value. And then there are other townsfolk, everyone else. And now suppose that you only have 100 tests at your disposal. So testing everybody is completely out of the question. And if I have group tests of size at most 64, then the question is, what's the best thing that I can do? And what's currently being done is, well, if policymakers are conscious of the health workforce, they might allocate 20 tests to the workforce, the health workforce. But for everybody else, we've seen that essentially you'll get tested if you're showing heavy symptoms, and maybe not even. And so these tests where you're already basically guaranteed to have the virus or may have high probability of having the virus are not very informative. There's an inherent bias in these results. Many cases go unnoticed, and you might not even have an idea of the prevalence rates in the country or specific locations. So here's a mild step ahead, which is just simply having one category and performing a uniform group test on the entire population. So bucket 100 groups of size 64 from this village, and that means that you cover 6,400 people, although at a less specificity. And so this already covers a lot of the population, and we can also estimate the prevalence of the virus. But some drawbacks are that we might unnecessarily, a healthcare worker might be in a positive group, and they might be healthy. So they might be at home instead of working. And also a marketplace worker might not be tested in the first place. And this is important because they might be sick and propagate the virus to many people. So here's a refinement with the main idea from our algorithm, which is to segment the population. And we already naturally segmented into 3 pieces. And let's allocate 20 tests for individually testing healthcare workers, 20 tests for the marketplace workers at granularity 24. So we still cover all of them, so none of them will go unnoticed. And then we allocate 60 tests for the rest of the population at granularity 64. We cover many people. We definitely cover all the marketplace workers who might spread the virus. And we don't have any false positives, positives for healthcare workers. And we can modulate the granularity of the marketplace workers if they can or cannot stay at home. So there's a lot of flexibility in this overall paradigm. And so just before reaching the final points, I just wanted to mention that there is this limit of 64 group tests that we put for now, but we can break this in a certain way in the sense that there are certain individuals who have a high correlation in infection. Imagine a household. If somebody's sick in the household, chances are everyone else is going to be sick. So there's no need to include multiple samples from a household in one test. Say, for example, you take 1 person per household, and now you can group households. And if now in our toy example, actually, if the average household is of size 3, then we have, then just 50 pooled tests over households, we can cover the entire population. So there's a lot of versatility in this paradigm with the limited number of tests that we have. And so just to conclude on some next steps and some opportunities for collaboration that we'd like to explore. So we've seen that this policy modulates between containing the virus and mitigating the impact of self-isolation. It'd be interesting to see how this is balanced at different stages of interventions from governments. Nor are we experts in the places where this could be of use, such as in Africa. And we'd love to hear from people who have a better idea of the ground truths. There's also the evolution of the infection. It depends on the policy, and modeling this is important. Past literature and group tests incorporate the techniques from. It'd be very interesting to see where that goes. And ultimately, we want to understand the intricacies of applying these methods around the world, and especially in hyper-constrained settings. And I believe that we could learn a lot from everybody here in terms of the realities where we could implement this. And ultimately, we want to see if we can maybe get some trials to get the project off the ground and see if this can be used in practice to help combat the virus now and help ease self-isolation in the future, because this has already been seen to be catastrophic in some cases like India, where the mass amounts of self-isolation are becoming a slight humanitarian crisis over there. But anyways, thank you all so much for listening. This is my email in case anybody wants to reach out, and thank you so much.
Thank you very much for that. I'm sure there'll be a lot of questions at the end of this session for you. So next, we're going to hear from Abimbola. I believe you're ready, right?
Yeah, I'm ready. Good evening. I'll be sharing my screen.
All right, so sure.
Okay.
Looking forward to your presentation. So save your questions on the Q&A for Francisco and all the others, and we'll handle them later.
Okay, saying I cannot share the screen. Okay. So, sorry, are you seeing my screen?
Yes, I can see your screen.
Okay. Hi everyone. My name is Abimbola Lale, and I'll be discussing briefly what me and my colleagues are cooking up. Though this research is still on, but I'll just make mention of little things we've been working on. Okay. So before that, I'll talk about where I work. I work with Data Science Nigeria, and we are key about raising AI talents. You can like I said earlier, I am Abimbola Lale, and I'm a data analyst at Data Science Nigeria. So the overview of what I'll be looking at is probably the introduction, then the little things about COVID-19 in Africa and also in Nigeria. And I'll also talk about the assumptions of the model and also the simulation study and the results. Okay, so it is COVID-19 is not really something new to us. We know it's an infectious disease that causes respiratory illness, and it later leads to cough and fever, and at a severe case, we have it leads to difficult breathing, and it leads to difficult breathing, and we according to the World Health Organization, COVID-19. Okay, according to the World Health Organization, there was a record of about 1.4, not less than 1.4 million discovered cases as at 8th April. That was yesterday, I think, as at 8th April, okay, as at 8th April. And out of all this, about over 1,000 cases have been recorded. Over 10,000 cases have been recorded in Africa, and about over 1,000 cases in South Africa. I think South Africa is still leading. I don't know yet. Okay, so now in Nigeria, the first case of coronavirus COVID-19 was recorded on the 27th of February 2020, where an Italian man came into the country and was tested positive. And later on the 9th of March, same 2020, the second case was discovered. And it was from the report, the man that was tested positive had a contact with the Italian man. And as a, okay, so now the main objective of my study is basically we are looking to build a conceptualized mathematical model to such that we'll be able to know the network or the way the disease will spread if there are different policies. Policies here, I'm talking about policies like shutting down of schools, shutting down of religious activities, and some other stuff like that, closing all borders and all other things like that. And we are looking at estimating when the virus might reach its peak. Okay, so we look into the SIR model is called the substitutable infectious recovered model, and it is a kind of model that separates the whole population into three classes, which is the S, the I, and the R, which are the susceptible, then infectious, and recovered. Okay, so based on this, okay, this is my based the methodology we'll be briefly working on there, and it's explain what S is. That is those that are not sick yet are in the population. The I, which are those that are infected. The R, those that have recovered from the virus or probably they itself. And major which are transmission rates. Okay. And based on this research we are carrying on, we made there are some assumptions that are still that are made, which are we assume that the population is fixed. We did not consider weather conditions. We did not consider the effect of natural birth rate and some other stuff like that. Okay, and the first simulation study we carried out was okay, based on we did we carry out a network analysis per se to know the way the virus might spread within a close population of 1,000, a close population of 1,000, where there is zero policy effect, light policy effect, and high policy effect. And the second stage was basically where I used the total population of Nigeria as at 3rd March, April, and I computed some other values based on the S, the I, and the R, and I did a simulation study on it to predict when or to estimate when likely the virus might reach its peak. Okay, so for the network analysis, for the network simulation, okay, this is what it looked like when the virus the virus started, and what it might look like at 100 days. That is where there is no policy effect, probably no policy effect, okay? And this is what it looked like when there is light. Oh, I use 500 days here. Then this is what it looked like when there is a very high policy effect. And we can see from the high policy effect, they are little, and some people has recovered. We can see the green, and some people has recovered, okay? And after all, this main simulation study, the SIR model, which is this, okay? This is the main SIR model, and the model was, the data that was used was based on data, was the data I collected from Worldometer as at April 3rd. And this is what it looks like, saying it might reach its peak in 25 days. Though, and there is one thing I want us to understand about this. This research is still ongoing. We are still trying to add more parameters, like the proximity risks, like state proximity risks, and some other things like that to make the model a better one. And okay, so with that, since it's saying that the disease might reach its peak in around 25 days. So then the government lockdown might do a good thing. That was based on the conclusion we made in this little study. And okay, stay safe, and I would welcome any question. Thank you. Hello?
Thank you very much. Thank you for the presentation. The questions will come in the end, so stay online,
Okay.
and stay on the panel. Next, we'll be having Brooke. I believe you're ready to make your presentation.
Great, thanks.
So anyone in the of the attendees, please continue putting your questions on the Q&A, and Brooke, as soon as you're ready, you can share your screen and proceed.
Great, thank you. Good afternoon, everyone. So I'm going to take you through what we've been working on in South Africa in terms of the epidemic modeling for COVID. And so what this has turned into is I've actually now have a mathematical modeling consortium for this. And so I'm going to talk about sort of the structure of the consortium, how it works, and where we are now with this. Yes, my name is Brooke Nichols. I'm assistant professor at Boston University School of Public Health, and I'm also affiliated and was based at the Health Economics and Epidemiology Research Office in Johannesburg for a long time, which is where this work is being run out of. So in terms of the modeling consortium, this was done in collaboration with the NICD in South Africa, as well as the Department of Health. And there's 3 modeling groups: the HERO group, which I'm part of, UCT had a modeling group, as well as SISIMA, who are a big epidemic modeling group as well. So all 3 of us have been working on our epidemic models, SEIR models, and deterministic models, stochastic models, to try to predict the future of the spread of COVID in South Africa. And so the government was looking for, you know, what should they expect in terms of cumulative cases detected, hospitalizations, ICU visits. They also wanted to know if we can use these models to help inform budgets and, importantly, resource allocation. So South Africa is quite interesting in the pretty stark disparity between the private sector and the public sector in terms of resource availability. So also looking to see if we can shift resources and utilize and maximize utilization of the private sector. So the structure of this consortium is that we actually, all 3 groups, we had pretty much daily check-ins with our fellow modelers. And twice a week, we would run our models and test the assumptions of people in the group. So we'd really go through our assumption worksheet, make sure we all agreed on the dodgy parameters that we were all assuming. And what was really great about this is that we had very open collaborative communication. And so we're always had Skype open and chatting all day as we were working through our models. And so we were able, with 3 different model structures, trying to see where our results converged and where they diverged and why. In this consortium, we have weekly updates with the government and also got weekly input from the Clinician Society of South Africa to discuss, since we're all modelers and epidemiologists, to discuss our assumptions and scenarios with the clinicians. What I found really interesting is also that clinicians have, much different insight, but at the same time, there's so much unknown that the clinicians' insight at this point was, fairly limited, and we were all reading the same literature. So in a way, modelers and clinicians were pretty much on the same page. So I'm going to take you through our model and the data sources. So once we first heard, that the first case had landed in South Africa, we started, what already exists that we can already leverage to start modeling it straight away in South Africa in response to the first case. And so the first thing we did is we rushed around and said, okay, well, what data do we have on hand and what can we use it for in order to make better predictions? And so we thought initially we gathered all of the GIS data that we had about where healthcare facilities and labs were, capacity information we crowdsourced through WhatsApp chains. Pretty much we had we understood how many hospital beds and ICU beds there were from an old document from 2012 or 2014, last time that data was gathered. We were able to verify the information from dozens of hospitals using WhatsApp chains, and people, actually doctors and nurses on the ground, who would send in their the verification of that. We thought that we had data on the underlying population by province and age structure, and also by National Living Index, which gives us some understanding of socioeconomic status. And that seemed to be very important when modeling COVID, because the age structure really is really important when determining how many severe and critical cases we might expect. And we also, due to the influence of COVID and comorbidities, we thought that understanding the number of people suppressed or unsuppressed on ART would be useful. So we gathered that information as well as TB. We've also gathered some information on NCDs. None of this we're able to incorporate in the first version of the model, but just to put it out there, what we attempted to pull together. And then also to assist with budgeting, pull together a bunch of costs. So once we had all this data together, we decided to utilize an existing model from the NEAR lab from the University of Basel in Switzerland. And then we wanted to make the model fit South Africa much more closely, because the NEAR lab model, you could choose the country you want to work in, but we know that South Africa, like every country in Africa, it's not a homogeneous population. There's different provinces, different social structures, and we need to take that into account when predicting the spread. So that's why we incorporated age straight in a different way in the social vulnerability index data as well. And so just to give you a sense of these population pyramids actually all look quite the same. This is for one province in South Africa, Gauteng. But you do see that in the lowest quintile of National Living Index or Social Vulnerability Index, there's fewer older people as compared to those in the highest quintile. And I can also map this out to look at social vulnerability geospatially. So this was incorporated. And then we also, a key part of all this is the underlying reproductive number, the effective reproductive number. And there's been plenty of papers modeling, what we expect this to be in different countries. But ultimately, I've seen papers saying, oh, South Africa's reproductive number is 3.2. But of course it's not 3.2 for everyone, for every part of the country. It's very different depending on where you are and the contact rates of different people. So I can go into R0 more deeply if anyone wants me to later. But just to give you a sense that those in the highest socioeconomic status, we assumed had a contact rate of about a reproductive number of 2.2, which is what has been estimated in Europe and North America, and then slightly increasing rates depending on your SVI, Social Vulnerability Index quintile. And so instead of saying, oh, the whole country has a very high contact rate, we assume that that differs by how closely people actually live together, and trying to make this distinction in the model was important. So given the timelines, we used the infrastructure from this model. You can see the link up there. It was also in a few slides back. You can play with this yourself. And like I said, the main issue is that we couldn't get to any sort of granular level in South Africa. So what we did was, this is the underlying structure, sorry, the SEIR model, because we wanted to take into account this idea that people are infectious, but not yet symptomatic. And this can drive onward transmission because it's not very easy to identify someone who is, who may be infected and is asymptomatic. So that's the idea behind the E in this model. So we popped the hood off the model. All of their code is freely available online in GitHub, and created a virtual machine and plopped in all the South African data that we wanted. So we could actually customize the interface for South Africa specifically. So when we had run the model with our own inputs, we then could say, okay, now we want the age distribution, let's say of Western Cape, and it pulls in the population distribution of the lowest quintile of socioeconomic status and the population distribution of that strata. We can also pull in the number of hospital beds and ICU beds that we collected. And we also built in some flexibility with a number of points for different mitigation strategies. So for example, we were on the bottom left here, we were testing what happens if we do lockdowns on and off, and then they work in varying degrees. Then the second part of this, to understand the epidemiology, this is what we use literature and consensus expert opinion from the Clinician Society and from the published and not yet published literature to try to figure out what this might be. And so we actually had even not just clinicians, but also climate scientists on the call to help us figure out what about seasonal forcing and using climate data to figure out when this might peak or what kind of forcing we should use by month. And then the clinicians were also very much helping with the hospital stay and ICU days that we might expect in South Africa, because it does affect the bed capacity. And then these are the parameters that we can use for calibration. So initially we had some data from the NICD about cases and whether or not they were tested in the private sector or the public sector. And so that helped us see the epidemic, which with approximate dates and number of suspected cases. So that's what we use that for. And then other things we can toggle, of course, are the reproductive number. Latency can change a bit depending on which paper you read, as well as the infectious period where you're actually contributing to the force of infection. So you're infectious for a lot longer than 4 days, but we assume that you have 2 days where you're asymptomatic and transmitting the virus, and then you have 2 days where you're symptomatic and possibly still transmitting the virus before you decide that, oh, you're sick, now I self-quarantine. So there might be sort of a continued infectious period where they might continue to contribute to the force of infection, but we truncate it. And just to show some model exports from this, so you see here that there's a run button, and then you can basically play with your toggles and say, well, what if we do 2 weeks on, 2 weeks off? What if we do one long lockdown? What happens? And compare the difference. What happens if our hospital beds increase in capacity, if we can create capacity in the ICU? And then you can run the model and you can actually export the underlying CSV files, which is really helpful. So what we would do is run this for each level of socioeconomic status, export all of them, and then tie them all together for the whole country. So one thing we did was looked at the effect of a once-off lockdown followed by light restrictions after that. So this might be, light restrictions might include still limits on travel and limits on public gatherings and gatherings over 10 people. Some say that this could be achieved with school closures, which would still, I think, be quite devastating. But just by this this one lockdown followed by light restrictions, you see that these are the curves that are generated by that. And so the non-ICU capacity is far surpassed during the peak of the epidemic, and both in the public and in the private sector. So if you just have this 120-day lockdown that South Africa's implemented, is it enough? Probably not to flatten the curve. And unfortunately in South Africa, the curve has to be quite flat in order to fit under the current capacity. So then we also looked at, well, what happens if we do some sort of cyclical mitigation strategy? And in the public sector, it doesn't really help too much. It gives you 2 peaks, but peaks are still quite high and exceed capacity. But the cyclical mitigation strategy works really well in the private sector. And the reason for that is flattening the curve is much easier and plausible when you have a lower effective reproductive number. So if we're assuming that people in the private sector can more easily self-isolate due to their living situation, that these mitigation strategies will be more successful there. So this is just, we were playing with a whole host of different strategies, but this is something that you can work in. You can work on these models for different countries and play with these mitigation strategies, which is quite cool. So after all of that, all 3 groups, after showing the output and trying to model similar scenarios and providing input to government, they've chosen the UCT model to be their primary model for the numbers for South Africa. So they chose the UCT model since it's stochastic. And that was their primary justification, which is cool, because now we're using our model for validation of the UCT model, and we're also providing direct input into their model now. So it's kind of great, because now we have all hands on deck into one model that we can all get behind, which is really neat. And so the HERO group is still mostly involved through in-depth parameter estimation, so taking the time to actually think through how things like HIV and NCDs might fit into this based on limited data available. We're also running a national budget model and resource need estimation and tools for that. And that is where we are now. And I'd like to acknowledge it's really been an incredible number of people involved in this, from the start all the way through now, people working 24/7 with several time zones. So we can actually work through the night, which has been very fun, sort of. For all of you programmers out there, y'all know it's fun. But if you want to contact me, feel free. I'm up all night. Thanks.
All right, great, thanks. I'm sure there'll be a lot of questions on that. Now, the last talk in this session is from Andre, and it's optimistic in that it's exploring lockdown exit strategies. I think that's a bit optimistic, so that's a good way to end this session. So I think you're ready, so go ahead.
I am. I'll see how optimistic I will be though. That's a question, really. Here we go. So can someone say, is it seeing what I'm sharing?
Yes,
Yeah,
we can see
yeah.
what you're sharing.
Perfect. All right. Okay, so good evening, everyone. My name is Andre, and I'm a PhD student in the University of Cambridge. And I'll talk about something that I've been looking at the past couple of weeks with my supervisor, Neil Lawrence. I do have to say that I could probably jump through half of my slide and probably to the last 3, because Brooke just did an awesome job of setting the scene here. But yeah, I guess I'll continue. I just get from start. Anyhow, so I'm sure probably most of you have seen this news that made around a couple of weeks ago, which is just a mind-blowing figure, right? It's like nearly half of the population of Earth is under some form of restriction right now. It gives me headaches to just start thinking about how did that happen. And obviously, a lot of countries are strained. Like this will probably take a toll on the people's psychic, people's health, obviously on the economy on the macro level. So probably most likely lockdowns were a right solution short term, but right now, I bet you every country that introduced lockdown is looking at how to exit it, right? Or how to go on with it. How to make it manageable for people and on a macro level as well. So this is the basic question that I will try to look at. And of course, the path we would like to take is to just vaccinate everybody, right? So we don't longer feed this virus, but there's obviously a problem with it. I'm sure most of you have heard that the vaccine is not around the corner. It's actually not until 2021, and that was being optimistic. So I don't think it's sustainable to think that we can be in that like strict lockdown mode for a long period of time. So every country needs some kind of a path towards it, to wait until the vaccine is here. And what to do, of course, you do some kind of simulation, as Brooke and as well as also told us, right? And we'll be doing the same. You can consider this talk as something that what an individual do if you're not like a part of a mighty group, like which is heard in the previous talk. So what we'll be using is this very well-known models that we've already had introduced. This model on its own is 100 years old. It's pretty well known. So you split your population compartments and you just describe the mechanics of the model with some kind of a differential equation system. But what we're actually interested in is how to model the government actions. And we'll use this revised model, which is much newer, so just a couple of years old. And we'll try to model the transmission rate, which is something that all the government elections are actually trying to affect as a function of time. How is that done? This is a very recent approach that was proposed just this year, just for COVID modeling. So we'll be using that. In this formula, obviously, beta 0 is just the initial transmission rate. Now, alpha actually expresses the strength of governmental response. And obviously, it ranges from 0 to 1, 0 being we just get on with our daily lives as normal. And this is not what we actually have right now. 1 would be, if alpha equals 1, that would mean that you basically have everybody, not just essential workers or anybody, like every single person at home all the time, isolated from everybody else, which I guess is also not feasible. So the real alpha is somewhere in between, right? The third term in this formula, we're not going to actually look at, but it's a very nice way. If anybody wants to have a look at the public response, that's a very nice and easy way to have a look at it. So, and model this kind of like basic idea here is that the more severe cases around the country and the more dead there in the country, the more scared people are, and the less they go into streets, no matter what the government says. Reach out to me if you want to do more details of this talk. So we'll set some context, and I'll use South Africa data as well. It doesn't really matter much, but I just figured that it would be better to just use some kind of abstract numbers. First set is like where we are right now. We're at day 38, 39 after we start the simulation. And just let's look at some ways that government could take this lockdown. So the most obvious one is what happens if we just end the lockdown as planned, right? Which I think is April 13th right now. We're not extending it. We're not doing anything. It's just like lockdown ends and everything goes back to normal. Well, of course, that the book will be highlighted that doesn't really work. Because we have a very huge peak very, very, very quickly, right? And it's basically, if we had this lockdown, basically done nothing. We could have as well just not do it. But okay, so this is what simulations are for. So we have some kind of baseline. Let's see what else we can do. Just as book highlight, we just play with this data and just see what could be done. So let's say we have a very strict lockdown, just like we said, for 6 months. Right now, this does work in the sense that it reduces the peak almost to half. But another thing that is very important, and it's very difficult to model. So I'll talk a little bit later about how we modeled it. But basically, it would cause the entire the loss of this lockdown was going to cause the entire budget of the country for the previous year. So I guess it's just not reasonable to expect something like that to happen. Okay, so that is another kind of baseline that we can think of. What if we don't actually force a strict lockdown? What if we allow disease to spread a little bit quicker, but not as quickly, right? What will happen? Okay, so this is kind of a half measure, so we kind of allow people to meet twice as frequently as they would under a strict lockdown. And you can see that we have about the same kind of peak number. It happens a little bit earlier, but it halves the cost, which is actually a win, right? And at this point, we can ask ourselves a question, which is what I've asked myself. Like what I'm essentially doing here is just playing with trying to find the optimal policy, with my objective being the size of the peak. That sounds like an optimization problem. So let's format it as an optimization problem. So here are some hyperparameters, and we're looking at 6 months, and we're breaking them in 3-week periods, and each period going to have a separate strength to it, kind of separately quarantine strengths to it, I guess. So that's a separate parameter for our optimization. And we also have an economic constraint. And this is where it gets very tricky, because the real impact of any kind of lockdown on economics is actually pretty hard to gather if you're just like a bystander like me. And I'm obviously not an expert in economics. So I just found one figure somewhere, and it's probably oversimplifying things a lot, but we're going to say that we have some kind of a limit, and the lockdown at its full strength is going to cost us that much money a day, right? That is probably, like I said, oversimplifying things, but it just shows you kind of the mechanic what you could be doing. And the result of such an optimization when you run it is that you can further reduce the peak considerably, and I guess this is not the limit. That is kind of the way that I wanted to show up how to what can we expect from the lockdown kind of policies in the next couple of months. And it's obvious that to some extent they will probably be softened, but it's an open question to how much, and we cannot really expect like total return to normalcy anytime soon, because as many people said, COVID is here to stay for a long time. So that's all I have for today. And thank you. I'll take questions in the Q&A.
Thank you very much. So I think I'd like to invite Elaine to take over the panel for this session. And but before that, I'd like, there is one person we're inviting to the panel who wasn't one of the speakers, and that's Abraham, who's from the Institute for Health Metrics and Evaluation. So maybe you can take maybe 2 minutes to introduce yourself, and then Elaine will take over the panel.
Yeah.
Maybe say a few words.
Thanks so much. Hello, everyone. My name is Abraham Flaxman, or AB for short, and I am a mathematician at the Institute for Health Metrics and Evaluation in Seattle, Washington. I used to work with Dr. Nasose when she was here. I miss her being here, but it's great to be on a panel with her again. And at IHME, we have been making projections using a very different modeling approach than the ones we just heard about. So it's been really great for me to hear about all the different work going on, all the different approaches, data, and models that everyone has been working with. The approach we have been taking, I consider sort of a statistical approach to be compared with the what I think of as more mathematical approaches that we heard about so far. Or another way to say it is that what we're doing is curve fitting. And we have come up with a particular parameterization of a curve that seems to fit well in Wuhan, China, where the epidemic has run its course, and then done as best as we can to predict how that curve might fit to the epidemics that are emerging in other locations. And we've been able to do this really starting with our own area in Seattle as an effort to help the hospitals that are associated with the University of Washington. But since then, we expanded it to US states, and from there to select countries in the European region. And for those of you who are not familiar with the Institute for Health Metrics and Evaluation, we get a lot of funding from the Bill and Melinda Gates Foundation, which is also here in Seattle, and they are very keenly interested in what is going to happen with the COVID outbreaks in the countries of sub-Saharan Africa. So we are getting a lot of requests to expand our approach to sub-Saharan Africa, and data and science are a huge challenge for doing this. So I really appreciate a chance to hear what all of you have been up to be on this panel, to have a chance to start thinking about what are the issues we're going to run into when we try to do that. Thanks.
Thanks, AB. So thanks to all our presenters. I'm going to go ahead and read some of the questions that have been submitted. So the first question is from Charles, and this is for Francisco. So has this model been put to active use with real data in your region?
Hi, Charles. Hi, everyone. Thank you so much for the question. And the short answer to this question is not yet. We're working on trying to get, because the difficulty comes in choosing the specific underlying model for the baseline probabilities and exposure for certain individuals. And we were thinking that even a blunt categorization might be something useful for policymakers, even if you have some blunt correlation between, say, age groups, and you say that a certain age group has a connectivity and a certain, there's some good information on probability of infection given age groups in Wuhan, China, in some recent papers. But we would still have to pull that together with some census data and try to get some answers still. So the answer to that question is not yet, but we're in the process and would love to hear more feedback in terms of how to do this right as well.
Thanks, Francisco. So the next question is for Olawale. How did you capture the diversity of the policies in your model?
Okay, yeah. Hello, can you hear me?
Yes, we can hear you.
Okay. All right. Based on that, I guess Charles was talking about the network, some stuff I showed, the network model, right?
I think so.
Okay, yeah, it was based on some actually the network model was based on conceptualized. I did not the values we used for that network was actually not real. It was based on what it will look like if this if it is like this, if there is zero effect policy, what it will look like if there is a light effect policy, and it is not a real model like that. The main thing I could talk about that it is real for now is the SIR that we tried, and we are trying to input more parameters to make the model rich. Thanks.
Thank you.
All right.
I think the next question is also for you.
Okay.
It was to explain when you talked about 25 days. So is that
Okay,
25 days from, yes.
It was from the day the model was built.
Okay.
Yeah.
I'm going to take some of the questions from YouTube. Let's see. So we have a question for Brooke. So does your model include HIV as a way, is your inclusion of HIV in the model as a way to control it? I'm not exactly sure what that question is trying to say.
I can talk a little bit about the idea of including HIV in the model. So what we initially hypothesized is that people who are HIV infected but are not on treatment might be more likely to have severe or critical disease. And we wanted to be able to take that into account if we observe that in the data. But we don't have any evidence to suggest that that's the case, but just to allow the flexibility in the model to be able to adjust for that if we need it. And I know that there's some trials ongoing to look at the prophylactic effect of tenofovir and intracitabine. This is totally hypothesis driven as to whether or not that would work. But if that did, that would mean people who are on antiretroviral treatment might be protected. So by having HIV in the model allows us to adjust for those things should they be demonstrated with data.
Cool. And does your model currently follow the current trend in the epidemic?
Yeah, so we spent some time doing the model fits. We decided to fit the curve instead to hospitalizations, well, fit the curves to the deaths we observed, because the tested cases are a really poor indicator of actual cases. I think probably a lot of us have realized that by now, is that the testing strategies in each country are so different. And in South Africa, most of the testing is being done in the private sector. So, you know, public sector testing is not yet ramped up, and we might, so I did do a lot of playing around with seeding the epidemic, and, you know, what if we're under-diagnosing significantly in the public sector? What does that look like? But so we tried to fit it to the death data, assuming that that would be more reflective than the case data.
Okay. Thanks, Brooke. So the next question is for all of you on the panel. So how can your models be used? How can your models be adopted for different countries across the continent? Brooke, maybe you can start.
Sure. Yeah. So I think definitely could be. I know that the modeling infrastructure is there and it's really available online, and we can, you know, if you want to use the NEAR models model and you need support trying to figure out what the input should be for your specific country, it can definitely help with that. Do some screen share hangouts on Skype and go through it. And I think we can share some of how we've been able to pop the face off of the model and been able to upload, you know, sub-national data to be able to get more granular level effects. And I mean, already in that model, I think you can choose from the national population pyramids of any country in the world. So you might even be able to set it already to the countries that you work in. And then the kind of information that you would then need if you want to look at resource allocation and capacity would be to get some sort of understanding of the number of public sector or the number of hospital beds and ICU beds available, just to see, you know, when beds might run out, for example. But yeah, their infrastructure is there, so it's definitely something that can be adapted to other countries.
Great. Ibi?
You know, I think it's really reassuring to hear others have also focused in on the death data as a way to understand what's happening with this epidemic, because that's, to me, the part that has seemed most reliable when looking in European and US high-income setting, where again, the case data is incredibly varied based on different strategies for who's getting tested, as well as different approaches to reporting the results of those tests. And I think the big question and big challenge in expanding this sort of approach to sub-Saharan African countries is to know what kind of death data is available and how varied should we expect that to be from place to place. And what I'm thinking about is we know that globally, not all deaths are certified. And a few years ago, there was even an estimate that only 1 out of 3 deaths globally was receiving a death certificate. And on the other hand, this is an outbreak. Everybody is looking for anything that might be suspected to be a COVID death. So will there be data sources that we can kind of translate between different locations on the number of COVID deaths? If yes, I think we really go after that. And if no, I think we're going to need to come up with really creative data strategies to fill that gap.
Great. Olawale?
All
Hello?
right. Yeah, from my point of view, the model can work in anywhere if there is enough information for it. As far as I'm concerned, okay, if there is enough information to build in more parameters that will make the model more richer enough, then it will be able to pick some things that it has not been able to pick where there is no much parameters, where more parameter are not included.
Okay, thanks. So one question I have is, we know that all these social distancing measures are not going to be 100% followed. So not everyone is going to sit in their houses. How do your models account for that? Anyone can start.
I think at least in ours, we account for it in a kind of blunt way, just trying to minimize the number of people who are asked to self-isolate unnecessarily. But it would be very interesting to see what the incentives are in play in terms of getting people to self-isolate, and even just the incentives of play as people start relaxing these self-isolation protocols. Who is it that's going to be able to walk the streets freely? I bring that up in the sense that if I have had the virus and then I'm able to, and then I'm healthy afterwards, am I then, as a young person, incentivized to try and get the virus as soon as possible, try to build immunity, thinking that I will be safe afterwards, and then have a green card to walk the streets freely? And what effects can this have for the overall hospital load are definitely very interesting questions for the
Let me just follow up on that before I go back to my original question. If you're looking at exiting lockdown for different countries, could you do that in use a phased approach, where instead of thinking everyone is going to come out at the same time, have people come out in different groups? Is that something that you can capture in your model?
I think in our in our model we look at phasing the importance that we place on this in the testing regime, but in terms of how this affects the spread, I think there are definitely people here who have a much more thorough working knowledge on viral spread models that might be able to chime in with much more domain knowledge for that.
All right, well, thank you. Do the other presenters have thoughts on how you would capture different effectiveness of social distancing in your models?
So we were going to take a more empirical, or the intention was to take a more empirical approach to this, to look at to do more model fitting in areas we know that have had stronger or have actually been following the restrictions, to try to see if we can estimate the effective reproductive number as we go along, and then sort of estimate, you know, if based on what we're seeing in the data, the interventions are working, you know, are reducing the number of transmissions by 30% or 40% or something like that. So the idea is to try to do that empirically and then fit, well, sort of empirically, modeling based on that data to then estimate the relative effectiveness by area. I don't know if that's going to work, but we'll see.
Yeah.
That sounds similar to the approach that we have taken. And I think of it as really having two prongs. First of all, we've been very strict in what we consider social distancing efforts. And we've said this has to be government mandated and it has to be for real. So now that we've put our model out there for US states, there's different journalists and different public health actors who have been calling us up and saying, hey, we've already done, let's say school closures. And we have really dug into the details and said, no, according to this, you said schools are allowed to close, but not required to close. So we're not counting that as a government mandated school closure. Or another example was the government mandated the closure of all non-essential services, but they said everything was essential. So it was not effectively closing anything, despite the letter of the law saying a closure of essential services. And we said that doesn't count. That is not something we expect to have the same impact as when Chinese government locked down Wuhan city. And then the second part of that is we have really assumed that these kinds of state mandated social distancing efforts, when strictly defined, are going to have an effect that's transferable between locations.
Mm-hmm.
And I consider this the huge hypothesis that goes into the IHME model, is to say other places are going to be able to crush the curve the way Wuhan city did. Now, there's some preliminary evidence coming in to support this hypothesis, but I feel like the biggest risk is now that we've put a model out there based on this hypothesis, that we've gotten invested in believing in the hypothesis. So I think we have to be very open to and very on the lookout for counter evidence that will refute that hypothesis, because that is when we have to really think about changing our model.
Thank you.
Yeah. So I just have a question for you actually about that. So so the IHME model, if you look further out into the future, I've only played with it in the short term, but is it actually able to squash it out, like bring the R naught below 1 and have the epidemic peter out?
Yes. Yes.
Wow.
And so we are saying,
and that assumes
for example,
like
in Washington
insane
State,
effectiveness.
the epidemic is coming down. And it's been a little bit of a paradigm conflict, because we don't talk R naught. We don't talk, for those of you who haven't heard these things before, R sub T is sometimes used as the time dependent reproductive number. But there's an implication in our model about what it implies R sub T is over time. And it implies that R sub T goes below 1 from social distancing in most of the places where we run our model.
Interesting.
That's interesting.
And how long does the pressure need to be to drive that down below 1 to then lead to the squashing out of the epidemic? Have you been able to tease that out?
Yeah. That that is something that our model fits empirically from data.
Okay.
So I don't know a date off the top of my head.
Sure.
But you know how in the sort of more, let's call it mechanistic modeling, where you think about a duration of from infection to onset of symptoms, and from onset of symptoms to death or clearing of the infection, that you might think that takes like 2 to 3 weeks. I think that the empirical results are in line with that. And so if
you take into account household size though, and potential for dragged out transmission due to household size?
We do not. And another thing that we don't take into account explicitly in the state models that actually is pretty important for the detailed model of the hospital system in Washington State is, let's call it, important subpopulations. For example, the outbreak in Washington State started in a skilled nursing facility, and we have broken out skilled nursing facilities in King and Snohomish County in Washington State, where the outbreak started in this state, to treat as a sort of separate and special population compared to the population outside of those particular facilities.
Interesting. Yeah, we found it very hard to squish it out to, flatten that curve long enough to drive if baseline contact rates and people are living really close together, we found that it's very difficult to sort of squash this out in the same way that we might be able to do in places like Washington State. Another thing we found that when we added imports into the model, so if you lift any kind of like travel restrictions and allow people to come in, that sort of immediately can reseed the epidemic, right? Anyway, so that's what we struggled with a lot, because as soon as we kind of relieve that pressure just a tiny bit, it's been reseeded with 2 or 3 people. They say it takes 4 to seed community transmission, and then it goes again. Just some thoughts on those.
Yeah, thank you guys so much. As if you're not doing modeling, as you can imagine, it could take several hours of discussions to figure out the assumptions that go into all of those models. So I think we've come to a close for presentations. We're going to have some concluding remarks from Shira and Neil. Neil, do you want to go first?
Actually, I think the concluding remarks will be done by Martin if he's available.
Oh, okay. I was looking.
Yeah, just briefly to conclude today's session, and I want to thank everybody for making time, and for the presenters for, you know, in such short notices, presenting all your nice work, and hopefully we'll, going forward, we'll have a lot more collaboration coming out of this, and perhaps a few more of these sessions. I think, Martin, are you able to
yes,
conclude?
Yes. Yeah. Yeah. I would say I'm still trying to fit in working from home. You know, the lockdown in Uganda is has changed my ways of working, and I was not sure how this this webinar would go, but I'm very happy that this has been a health discussion. And as Shira has said, I think this is going to start off networking and collaborations for different things, for models, you know, for quality data, you know, for visualizations, and all these geared at helping our governments to contain this this flu that, you know, has turned into a pandemic. Yeah, so at Pulse Lab Kampala, we are looking, as Maureen said, we are looking at several things. We are still receiving several requests from UN agencies and NGOs on how we can support on this. And we are also in different task force teams in Uganda. And I think this is going to be a helpful avenue to discuss some of the things that we shall be doing, but also learning from what other people are doing, and also trying to sell this to our government here. I would like to thank, people who have put in a lot of effort into this, in organizing this. I would just mention a few. I think Neil, Shira, Elaine, and Billy and others, and other members of the DSA community. I mean, this has really been good, and this is just a start. I think it will be great to discuss, and we know when to schedule the next virtual webinar like this, such that we can continue, you know, discussing and brainstorming on ideas that can support African governments to deal with this disease, which, you know, came as a surprise to everyone, and everyone is kind of panicking to see how to contain the disease. So we shall keep on posting messages on the DSA Twitter page, and then also I've been trying to add people to the Google group, data-science-Africa. So if some people have not yet been added to this group, they can, you know, reach out to me, and then I'll add them, or they can reach out to any one of us, and then we can add them to that, such that we keep these discussions, this discussion live, and such that in the end we are able to have some good solutions that can support our countries. I think that's all I would like to say. Shira, if you have anything else.
No, I won't extend this much longer. It's thank you for your attention for almost close to 2.5 hours. We really, I think, had a very good time. I would probably just ask anybody on the panel who may want to say something, and we still have 3 minutes. So we're really great that this thing ran on time. The gods
I
have
just
been
wanted to thank you guys
favorable.
so much. This was really cool, and I've already had so many people reach out, and so I really appreciate everyone taking the time to be part of this. It's really great. Thanks.
Yeah, and thank you
Agree.
for putting in all the work.
Thank you so much to the organizers. Thanks to all of the other presenters and panelists.
Yeah, really a wonderful event. Thank you all so much.
Okay, so stay safe, everybody. We'll be reaching out with maybe some feedback forms, but thank you for taking all this time to share, and hopefully we can all together, dent and put in our efforts to helping in fighting the pandemic. I think I'll close it off now. Thank you very much.
Thank
Thank
you.
you.
Thank
Bye.
you.
Thank you.
Thank you, everyone.
Bye-bye.
Bye.
Bye.
Bye, everyone.
Bye-bye.